Hey, I'm Matt Geiger. I'm going to explain in this video how the US health insurance system works today. In the United States, here's the breakdown of how everybody gets their health insurance. About half of citizens have health insurance through an employer, 17% are covered through Medicaid, 17% Medicare, 5% have non-group health insurance, and 1% have health insurance through the military. And that leaves 9% of people who are uninsured. Each of these groups are set up a little bit differently with different players and different incentives, so I'll walk through how each one works. Let's start with the largest bucket of coverage. 51% of all people are insured through their employer. Under most of these policies, an employer negotiates a lower group rate than each individual worker would be able to get on their own, and then on top of that, the employer usually pays a portion of the cost of the premiums. Premiums are monthly amounts you have to pay just to have insurance, whether or not you actually use any health care. Here's the general framework for how this relationship works. An employer's HR department hires an insurance broker to help it find the best policy fit at the best price. The broker will work with insurance companies to recommend an insurer to the employer based on what the employer is looking for. And then the employer picks an insurance company. There are two different ways a company can insure its workers. The first way is what you'd normally expect. The insurance company collects monthly premiums and uses them to pay out the healthcare claims to doctors and hospitals. That's called fully insured. The other way is called self-funded. The employer pays the insurance company fees to process claims and negotiate contracts with hospitals and doctors, but ultimately the employer is the one taking on the risk of healthcare costs. About 60% of employer benefits are self-funded. Mostly the larger corporations that are able to save money by taking on that risk themselves. In general, premiums and deductibles have both gone up a lot on employer policies over the last 10 years. Deductibles are the amount that you need to pay out of pocket before the insurance company pays anything at all. Premiums are up 22% over 5 years and 54% over 10 years, but deductibles are up at the same time, 36% and 100% over the last 5 and 10 years, all far outpacing inflation. In other words, employees are paying more for insurance, but they're also paying more out of pocket for their healthcare too. The main concerns around healthcare have to do with these rising costs, and to understand why that's happening, we need to understand the incentives of every player and how much negotiating power each player has, starting with a view of the employees. In surveys, health insurance ranks as the most important benefit to employees and a top factor that employees consider when determining a job change. According to research, most employees just want to keep their benefits the same as they are now. In surveys, 58% of employees are satisfied with the current level of health benefits they get, with 18% wanting more benefits with lower wages, and 24% wanting less benefits with higher wages. Employers are ultimately the ones choosing the insurance policies, and they're weighing attracting and retaining employees on one side against the cost of sharing premiums on the other side. It's a benefit that's basically essential to attract employees because of how much more expensive it is for employees to get health insurance on their own. Employers get tax breaks for health insurance that individuals don't get, and insurance companies give employers better deals because working through large employers takes care of adverse selection. That's when only sick people choose to buy policies. Because of all the competition for employees, the employers are not seen as having a lot of bargaining power. To attract and retain employees, employers need to compete with one another by offering larger networks of hospitals and doctors. And just to explain what a network is, the network is all the doctors and hospitals that an insurance plan covers, meaning that the insurance company has negotiated and agreed on rates for their services with each individual hospital and doctor. The wider the network, the more expensive the doctors and hospitals it needs to include, and the more expensive that the plan's going to be. So for employers, cost and network size is a trade-off, and network size tends to win out so that they can attract and retain employees. A lot of times the employer will bring in an insurance broker to help them compare policies and navigate all the nuances and set up with insurance policies. Brokers have the obvious incentive to keep the employers happy by maintaining their relationships and helping the employer achieve their goals, but it's important to understand how brokers are paid. The employer pays nothing. Usually brokers are paid in the range of 3 to 6% of the premium payments paid to the insurer every year the policy is in place. And insurance companies offer the brokers volume bonuses too. So there's also that very bad incentive brokers have for higher premiums and favored insurance companies. Then you have the insurance companies themselves. To come up with prices and network inclusion, insurers negotiate contracts with hospitals and doctor groups. The reimbursement, that's the amount that insurance companies pay for procedures, supplies, checkups, everything is negotiated. Then the insurance company actuaries estimate what their claims will cost, and they add a markup for admin and profit to figure out what they're going to charge employers on premiums. Because insurance companies make money through that markup on what they expect to pay out, they're not really as concerned with controlling what they spend out. In fact, by law, insurance companies need to pay out at least 80% of their premiums for medical costs, or they have to rebate it back to customers. So insurance companies actually have an incentive to have contracts with as many doctors and hospitals as possible to offer larger, more inclusive, and more expensive networks. This is a win-win for the insurance company. They make more money with broader, more expensive networks, and their customers, the employers, currently want those inclusive networks. A lot of times this means insurance companies must strike a deal with hospital groups with strong reputations or local monopolies regardless of the cost. On the flip side though, insurers can dictate the terms to smaller healthcare providers and those in areas with lots of competition, paying them less to get them in the network. What we see in the research is that prices are highest in areas with local monopolies of healthcare providers and lowest in areas with more than 3 different hospital systems competing. So this indicates that insurance companies do make some amount of effort to control cost. Insurance companies still need to contain costs to some extent to compete for more customers, aka the employers. But the dual impact of higher profits and employers demanding broad networks ultimately means that hospitals have significantly more negotiating power on prices than insurance companies, which is why prices keep going up. Our final player here is the healthcare providers, and I made a whole other video covering them because they really deserve a lot of attention, but the key here is that there's been a lot of consolidation, so they're able to negotiate higher reimbursement rates with little localized competition among hospitals. So that was employer health coverage, and that gives us some nice context for the other coverage types I'm going to talk about. Our second largest source of health insurance, insuring 17% of people, is Medicaid. Medicaid is intended as health insurance for people who don't make enough money to afford health care. Under the program, the federal government gives states money, matching what each state spends dollar for dollar, so they cover 50%. And then each state runs Medicaid however they want. Who's covered, what's covered, how much participants pay, and administration is left up to the states. So as you'd expect, that varies quite a bit. So I'm not going to get into all the specifics since it does depend on the state, but on average, states spend 17% of their general funds on Medicaid, so it's a big portion of state government. To get any matching dollars from the federal government, states have to open Medicaid to low-income families, and really, in this context, that means children and families with income below 138% of the federal poverty line. That's about $30,000 a year for a family of 3. People who are pregnant with income below that 138% of the federal poverty line, and most seniors and people with disabilities who get money through supplemental security income, and parents or caretakers with very low income, and very low income is defined by each state. So the range is pretty big, anywhere from $3,000 a year to $45,000 a year for a family of 3. Part of the Affordable Care Act, or Obamacare, was intended to standardize the definition of very low income at 133% of the federal poverty level for all adults, and the federal government would pick up 90% of the increased expense for that as opposed to the normal 50% with traditional Medicaid. Some states signed on for that and others chose not to. Here's what the Medicaid relationship looks like. Obviously, this will be a bit different for different states, but I'm showing the most common arrangement. You can see that the federal government provides matching contributions to the state, and then the state typically pays a fixed amount per member per month to a managed care organization, or MCO. A lot of times the MCOs are subsidiaries of bigger insurance companies, and they're the ones actually insuring everybody. So the states typically aren't insuring Medicaid patients directly, although some states do. The way Medicaid works for patients is pretty straightforward once they have it. No deductibles, premiums, or copays, and healthcare providers who decide to accept Medicaid agree not to charge the patient beyond the Medicaid reimbursement rate. Medicaid pays the least among insurers, so about 30% of doctors nationwide don't even accept it at all, but that rate varies state by state. Like we did with employer health plans, we need to look at the incentives here. For the states, there are the usual political pressures on both sides of the social services debate, which is the biggest reason for the very different Medicaid arrangements. Once you get past that layer to administration though, state governments have historically tried to reduce risk by outsourcing to MCOs. Cost control is a significant factor. As I mentioned, it's a huge chunk of state budget, and there's a rule that state Medicaid programs must be actuarially sound. Since MCOs are paid on a per member per month model, the MCOs do have incentive to control what they pay out so that they can make money. Unlike with employer health insurance companies, there isn't a strong incentive to build a big network at any cost because they can't just pass on an actuarial markup to people. Patients want good care with lots of options, but the reality is that they're getting free care and they don't really have a whole lot of power to influence Medicaid plans except through the legislative process in many states. The end result is all this is a cheaper insurance system with narrower networks. Coming in at 17% of all coverage in the US, Medicare is the third most common form of insurance. Medicare is health coverage for people aged 65 and older, and unlike Medicaid, it's entirely a federal program. Medicare is separated into parts A, B, C, and D. Part A covers inpatient hospital stays with an upfront deductible per visit of about $1,000. Part B is for outpatient services, so treatment without being admitted to the hospital, and that's essentially a co-insurance agreement where Medicare pays 80% and the patient pays 20%. Part B is elective, and you have to pay a premium on top of that. A lot of times people will buy extra private insurance called Medigap to cover that 20% coinsurance part though. And here's the relationship map laying out traditional parts A and B. Those make up about 2/3 of Medicare spending. In this relationship, the federal government is the insurer, so individuals enroll directly with the government, and Medicare is the one cutting checks to doctors and hospitals. No private insurance companies are involved. Medicare Part C is known as Medicare Advantage. Part C lets people get private insurance that covers at least the same conditions that Parts A and B cover, and then Medicare pays the private insurance the same amount it would have cost Medicare to cover that person. The majority of these plans are HMOs, where you're limited in which doctors you can see, but they make up for the limited network by including extra coverage like vision, hearing aids, dental, prescription drugs, and fitness centers. Medicare Part D covers prescription drug plans. These are private plans approved and regulated by Medicare in terms of maximum deductibles, structure, required drug coverage, things like that. And in return, Medicare subsidizes these drug plans for low-income seniors, and also if catastrophic drug expenses exceed a certain level. The relationship maps for Parts C and D look a little bit different than A and B, almost closer to Medicaid. In the case of Part C, the federal government is paying a private insurer who is then the one who's actually insuring patients instead of Medicare. And in the case of Part D, the plans are effectively subsidized by Medicare to make it more affordable for everybody. Medicare is mostly funded out of the payroll tax on your salary. The Medicare portion is 2.9% of that, half from the employer and half from you taken directly out of your paycheck. The rest comes from deductibles and, in the case of Parts B and D, premiums. Just like employer-provided insurance and Medicaid, you've got to talk incentives. The incentives for the federal government are really political, convoluted, and impacted by special interests throughout the process, but we can gain a deeper understanding of it by getting into how Medicare rates are actually set. Medicare reimbursement rates are set by CMS, Centers for Medicare and Medicaid Services. For hospitals, this is primarily based on a cost-plus formula, and for physicians, these rates are set based on significant input from the American Medical Association. CMS has historically taken about 80% of the AMA recommendations, so the medical industry is very influential in setting physician rates. These rates are balanced, so some rates need to decrease if others increase, but they still leaves the clear incentive to increase reimbursement rates on the fastest growing areas of medicine like tests, lab, and procedures to increase reimbursement as a whole. Beyond CMS, Congress is a significant player. Congress has a strong incentive to go along with medical industry groups like the AMA because they make up the largest lobbying efforts in Washington. And on top of that, doctors and hospitals are directly impacted by Medicare, while the average person is only indirectly impacted. 5% of all individuals are insured under individual insurance policies or non-group policies. So these are people who are unemployed, self-employed, or their employer doesn't offer health insurance. The relationship here is pretty straightforward. An individual buys a policy directly from the insurance company. About 2/3 of people with individual policies are under policies on Obamacare exchanges. The Affordable Care Act had its biggest impact on these types of plans. The ACA was signed by President Obama in 2010, and it says that policies can't exclude people for pre-existing conditions, and insurance companies can only charge higher premiums based on two factors, geography and age. Obamacare lays out a list of essential health benefits that policies must cover, basically anything that a typical employer plan includes, like hospitalizations and maternity care. That law also bans insurance companies from capping total payouts, requires out-of-pocket maximums, and requires requires insurance companies to spend at least 80 or 85% of insurance premiums on healthcare costs. State governments need to approve all plans on the exchanges, which means they can negotiate prices and additional coverage if they want to. For people making between 100% and 400% of the federal poverty level, they get a fixed subsidy that offsets the cost of health plans so that a household roughly pays between 2% and 9% of their income towards the second cheapest tier of policies. The subsidy amount doesn't change, but people can choose to apply their subsidy towards a more expensive policy if they want to. So let's talk incentives here. Since individuals get a fixed subsidy, people have an incentive to buy the insurance that they see as the best value for their individual situation, weighing the cost of what they're actually getting. So that's basically the intent of creating a marketplace. But beyond that, the majority of people are buying insurance at a severely discounted price, so the larger incentive is just to buy insurance from the exchange versus going without insurance. Insurance companies in this scenario have competing incentives of maintaining broad networks of physicians and hospitals while keeping pricing low to get more buyers. Since it's so easy to price compare on the exchanges and harder to look at the strength of the network, there's a greater incentive on the marketplace for insurance companies to provide HMOs or other less expensive plans. So that leaves 9% of people who have no insurance at all. There's a complex incentive system in place that seriously hurt these people the most, but I'll get into that more in my videos on doctors and hospitals. So the takeaway here should be that everybody in this system responds to incentives. The healthcare system is confusing, but it's not some big mystery, and it's not that a market for healthcare is impossible. It's just that we've created a system of horrible incentives. Individuals are pushed to employer plans because of favorable tax law and the lack of laws to tackle adverse selection. Employers are pushed to offer policies with the broadest network so they can compete for talent. Insurance companies are happy to offer these expensive policies, knowing that they make a percent of the premiums, and by law they must pay out a certain percent regardless. And when an insurance company knows it must negotiate a deal with the local monopolized hospital system at any cost, the insurance company has no problem rolling over and paying out more. But despite all this, I'm actually hopeful. All these players respond to incentives, and that means we actually do have the potential to design a system that actually works if politicians have the courage and wisdom to look for that deeper solution. Thanks for watching. Hey, if you found this video interesting or useful, please give it a thumbs up, put a comment below, and subscribe to my channel to get any updates on new videos. If you didn't like it, you should probably go ahead and put a comment below too to let everybody know. Either way, thanks for watching.